Thanks for the comment, Ruds. I agree. People need to know in a compassionate way what full code means. And after I have that first conversation with them, right, at the end of your life, what do those days look like? And if for that family, as it is for many, if it is breathing tube or CPR or surgical interventions or ECMO or transplant or dialysis, whatever, I tried to give them a rough idea of what the upcoming days could look like. Now, from the surgical perspective, I am very quick to outsource that information to the expert, right? Like if someone has severe mesenteric ischemia, they have dead gut, they need a colectomy, I know nothing about that. I will defer to the surgeon. My goal is this a conversation that you even want to have? And for many, it might be yes or no. But there are ways you can set up the ICU for success by managing their expectations, right? If they have a new creatinine of 5 and they haven't made urine in 2 days, right? The conversation of, hey, dialysis or a catheter that goes in the neck or the groin or whatever that helps facilitate dialysis could be a conversation you have in the next 2 days. I remember being an intern vividly in the ICU who had to have these conversations with families for the first time, and they had no idea it was even on the realm of possibility. An intubation, like any other procedure, might necessitate more procedures. You're not sure if their lungs would heal enough for them to breathe on their own, or they would have enough of a mental status to be extubated. So I agree with you, patients need to have a full understanding, to the best of your ability, of what the days can look like. But if the conversation from day one is, Grandpa's 97, he wouldn't want any of this, I don't want dialysis, I don't want to be intubated, I don't want CPR. If that is already listed somewhere, or if the patient or the family make that explicitly clear to you, you can save them from some of those difficult conversations.